What do you think are the underlying problems of meeting the needs of children when there are mental health issues within a family?
I think one of the fundamental things is that we, in many respects in our services, don't think family frequently enough. As time has gone on and we've become more specialist in the way that we deliver care, and we've lost genericism, there's been too much of a focus with some people focusing on the needs of children and others focusing on the needs of parents, and we don't have a family-centred approach. That means that for children growing up in families, sometimes mental health services don't keep them sufficiently in their view, and as a consequence, the children can sometimes be invisible to practitioners. And on the other hand, where the focus is perhaps on meeting children's needs, the identification of the needs that parents might have to improve their parenting skills get lost, and the focus really is on children with the exclusion of their parents. And I think one of the things that we're focusing on now in Wales, in many of the approaches that are being taken, is to move towards a family approach with a real family focus, and recognising that meeting the needs of the entire family is crucial if we're going to safeguard the children and we're going to ensure that we're meeting the needs of parents and we're driving up the skills and their abilities to parent effectively.
Children and families in Wales, the measure. How do you think this will lead to better outcomes?
I think we've got two measures that really do overlap very effectively. We've got the Children and Families Wales measure, which has got some core components in that, which is driving us towards a think family approach. We've got the introduction of the Integrated Family Support Service, which is very much focused on therapeutic approaches through a relatively brief intervention with the family, but which is designed to change the trajectory of that family and thinking about how the needs of the whole family can be met, taking a whole family approach, looking towards a family plan which integrates the needs of the parents and integrates the needs of the children within a single plan that will deliver a much better family approach. The other part of the measure, which hasn't been enacted yet, requires adult services, both health and social care services, to take into consideration the needs of children when they're looking at parental community care needs and parental health care needs. So if the condition of the parent, whether it's a substance misuse problem or a mental health problem or a learning disability, are affecting their ability to parent, those needs should be incorporated into people's planning around how those needs will be met. In the Mental Health Wales measure, they're taking some of what's embedded within the care programme approach now, and they're making sure that when people are having a holistic assessment, looking at developing a care and treatment plan, that their ability to parent and meet other caring responsibilities are considered in the plan of care to make sure that we're meeting people's needs holistically, and we're helping them and helping their mental health, improving their mental health by making sure that we're focusing on their needs as parent, as carer, and seeing that as being core to what makes that person who they are within the family context.
What challenges do you face in putting all of this into practice?
I think, and I'll answer this question again at this stage, is I think one of the things that really has a bearing is the culture and of the organisations in which we work. Sometimes they are set up, and going back to a point I made earlier, that we have seen services move away from each other, and rather than taking a partnership approach, that quite often the focus is centred on one member of the family or one component of the family, and that's become embedded in the culture, and cultural change is a real driver here. There are other issues like the ability of people to feel that they can share information freely, particularly perhaps between primary care with secondary care colleagues, between people who work in particular specialisms. Importantly, as the third sector has become more and more important, whether statutory services share information with the third sector. So there are, I think, cultural issues and cultural barriers which we need to focus on and work on.
GPs are being asked to think holistically when it comes to mental health issues within the family. What's the starting point?
It follows on from what Phil's been saying, really, except perhaps a GP is going to be on his own and he's got a patient with problems and thinking, perhaps assessing, what am I meant to do? It's not rocket science, it's common sense. They're professional people. they first of all need to find out whether their patient with mental health problems is in fact a parent or caring for perhaps an elderly person with problems as well. So always think about the patients as parents. Actually, it also applies for people with terminal illness or serious illness as well as mental health problems. So it's not just mental health problems. It isn't rocket science. We're asking GPs, perhaps they can get more information from their health visitor or school nurse about, is the child going to school? Are things okay from a developmental perspective? Are they meeting the basic needs of the children in their care? Are they being immunised? Are they being taken to appointments? Are they giving them stimulation? Are there any rumours going around in the community about problems? So they can ask that. They can also ask us a simple question, would I let my child be looked after by this person? So that gives you a very sort of straightforward, plus a snapshot of their parenting capacity. If they have got serious concerns, then, or they're not quite sure what to do, they can ask for further advice from their safeguarding colleagues. If they're really concerned, they should make a referral, make sure it's clear that they're making a referral. They don't have to have consent for that. But perhaps what might be more appropriate is if they've got problems about the illness of their patient impinging on their child's development, they can actually discuss with the patient and ask for further help as a child in need, because that child growing up in that family may well have needs.
Confidentiality in a GP practice. What should a GP do when a social worker calls and asks for information?
It's again, it follows on from what we were talking about with assessing parenting or sharing information. First, basics really. If you get this phone call or the visit, you need to find out who they are, who they're representing, what are the problems, what are they going to do with the information that you may or may not give them. So you actually got to ascertain that and write down everything. The GP should always make a note of such conversations. That's really important. So once they've established who they're talking to and why, and other possible safeguarding issues in the children of their own patient, they do have a duty to share as much relevant information that they have about that patient, about their mental health problems, about their appointments, about their medication, about how their illness may be impacting their ability to parent. And it's that duty to share that information goes against quite a lot of principles in primary care about confidentiality. But if there's any risk of safeguarding or the likelihood of significant harm, they really have a duty to share that information. And they should justify the fact they're breaking confidentiality. They should, ideally the patient should be informed that's happening. It might not always be possible, but it overrides everything from the Data Protection Act, from human rights. Safeguarding is actually paramount, and they need to share what they have. They use the term proportionality, which is quite a long word for just sharing what's relevant. And at GMC, I think have issued new guidance reinforcing this message. It's always been there, but perhaps some practitioners aren't happy with it, or they haven't always shared enough information.
Another issue is serious case reviews. What should a GP do about releasing information under those circumstances?
That follows on from our last point about confidentiality, really. Serious case reviews are undertaken when children die or are seriously injured as a result of child abuse or neglect. And they will also do it when there's serious sexual abuse, and more recently, if a child has committed suicide, there needs to be a serious case review. And since 2006 or 2004, they do serious case reviews where children are injured when the perpetrator has mental health problems or a mental illness. So we need the records of the adult patients when we're doing serious case reviews. It's meaningless to try and do them without those records. We don't have to have consent to actually seek the information from primary care records. Can't do it without primary care records, absolutely essential. But it's good practice to tell the person whose records you're looking at that you're actually accessing these records. Again, the general practitioner needs to be sure that the information is going to be used properly and fairly and legally processed. So it's not so much getting the information, it's what you do with it when you've got it. But it's pointless doing the serious case reviews without that.
Tell me about the shift that GPs need to make in terms of moving away from ways of working that they're familiar with to operating in new ways in relation to this area of their work.
I'll start off briefly because I think it's more really about the measure and how that will help them, because I think that's really important. Yes, we are trained as individual doctors, and I think GPs have always had this about confidentiality, the Hippocratic Oath. I think things have changed, and especially with the duty to share information and knowing your background and be confident. I think younger general practitioners find it easier than perhaps more established ones who perhaps trained as long ago as I did. But I think the present progress and the developments that are happening now with the measure and what's going on more generally and the support that's going to be there is going to make it easier. Do you agree?
I do agree. I think there are two things. One, which I think has to be absolutely highlighted, is a parent having a mental health problem doesn't make them a bad parent.
No.
In fact, many people with mental health problems make excellent parents and are very focused on their own needs and the needs of their children. So I think we do need to be clear with GPs that this, and they will know this, that simply the existence of a mental health problem doesn't necessarily have an impact on parenting ability. The second thing is that parents being assisted to parent more effectively by having their needs met, and a recognition that being a parent is very hard. It's very hard for all of us, and it's particularly hard if you're having a problem with your mental health where you may be anxious, you may be depressed, you may have a psychosis. Those things make a very difficult job even more difficult, and getting the help you need to improve your own mental health and to recover and to recognise the support you need in carrying out the parenting role is crucially important for GPs and other people working in primary care to recognise. So, and I think one of the things that many people with a mental health problem have voiced is, I'm a parent first and a person with a mental health problem second, but as a parent I want that to be recognised as part of what makes me me, and how you can help to meet my needs and by doing so meet better the needs of my children. And I think they are lessons that have to perhaps, if they've slid, be reincorporated into the way that people assess in a holistic way. And that's very much what lies behind the measure. It's some of where lobbying groups, in particular in the third sector, have been saying these are things that we really want to see recognised. But they go very much to the heart of seeing people as people rather than seeing the diagnosis, and that's really crucial.
And finally, what about services for children with mental health problems?
Services for children with mental health problems or issues, the service is very, very stretched. There are dedicated people doing a phenomenal amount of work, but difficult to recruit. Lots and lots of problems, and I think they do need a lot of support. It's very common, and your GPs are going to see a lot of children with such problems, and perhaps the support services may be a bit thin on the ground. But it's awfully important to try and help them and support them so they don't then become adults with similar problems and then parents, and it starts all over again, and we need support from an early age.
And we know, though, that early intervention is very important. And so intervention at the primary care level is critical. So it's identification, it's understanding, and it's also sometimes not about looking too soon to make a diagnosis, because the breadth of distress that children experience when they're growing up is very broad. Some of that might be a mental disorder, some of it might be very usual childhood experiences, experiences of bereavement, experiences of loss, experiences of separation, experiences of abuse can all impact on the mental health and well-being of children. And looking in very broad terms about well-being and about their emotional health, rather than just focusing on diagnostic categories again, is very important. So early diagnosis, early intervention is critically important, as is a broad view of mental health and well-being in children.
And
but I echo the point.
Yes.
But I echo your point, which is about the stress that the children and adolescent mental health services are under. But we need to increasingly focus on those services, because they are the things that will improve the mental health of the population of Wales in the longer term. Because if we get in early and we help people and we deal with those emotional issues that people experience as just the normal process of growing up, then the better. Because I think there is an increasing awareness of the fundamental importance of resilience. We can't make the world a nicer place, but we can help people to be stronger, to live in it. And that's what I think primary care and helping children, not just primary care, but schools and the broader society, by focusing on the emotional health of children, will in the long term give us improved mental health in Wales. And I think that's a really important message for a conference like this, that we recognise the breadth